Hey everybody, welcome to the video update for our upcoming protocol revision. In this video, we're going to cover the protocol update in detail, going page by page and looking for everything that's been changed. In the draft copy that you've received, every item that has an adjustment compared to our current protocol version has been annotated with a small green box. We're going to cover all changes, big and small. The big ones I'll mention, but you'll receive in-depth training in your upcoming CE cycles. For some of the small ones, this may be the only time you hear about them. I'll do my best to explain the rationale and the medicine behind them. But if you have questions, please send them over or save them for some of our protocol Q&A sessions that are coming up in the upcoming CE. With that, let's get started. All right, so the first page that has some edits on it is the adult patient assessment page. There's two big items that we really included on here. The first one is some discussion about DNRs and when they apply. There's a common misconception that DNRs only apply once a patient has gone into cardiac arrest. But in fact, the procedures that are listed as something that the patient doesn't want to go through towards the end of life really are prohibited throughout their care, whether they're already in cardiac arrest or are near cardiac arrest. So specifically, bag valve mask ventilation or any other positive pressure ventilation, advanced airway management like the placement of a supraglottic airway or an endotracheal tube, any CPR, and then really electricity, things like pacing, cardioversion, defibrillation. Those are clearly listed on the top of the DNR, and whether the patient is currently in cardiac arrest or, let's say, has a profound bradycardia with hypotension, in those instances, it still applies. So you would not start bagging a patient who has stopped breathing if their heart is still beating. You would not start pacing that person. But anything that's not listed on the DNR is still appropriate. So something like epinephrine administration or IV fluids. But remember, use your clinical judgment. These patients are towards the end of life. They've made their case known that what they would like towards the end of life and what they would not. And if there's any questions, as always, feel free to call us. The second change on this page is what we already discussed during the crashing patient protocol training. This talks about patients in extremis, looking specifically for things like new onset altered mental status, airway issues, severe respiratory distress or respiratory failure. And again, we push on this concept of go through the crashing patient protocol, meet your goals, and then move them to the truck. There's no point moving a patient who's not yet stabilized to the ambulance because they run the risk of decompensating and going into cardiac arrest. So those are the two big changes on this page. The next page with a change is the adult crashing patient medical. So again, you've already received your training on this. Just as a reminder, the goal of the crashing patient protocols is to give you a standardized framework for how to approach those critically unwell patients, giving you benchmarks and goals to meet before it's considered safe to actually move these patients to the ambulance, and really for us to work together as a team towards meeting these goals. Compared to when you had the training a few months ago, there's one other update that's going to be included in this as we go out with this next protocol set, and it's something that you're going to see pushed throughout these protocols, and that's the inclusion of push-dose pressors, specifically push-dose epinephrine. This is actually a really great thing because as we're aware, bringing the pump with you into every patient case doesn't happen, and also is fairly difficult. The use of push-dose epinephrine is going to be there as a sort of a stopgap between a critically unwell, hemodynamically unstable, hypotensive patient. You'll be able to administer push-dose epinephrine at the bedside in order to temporize them towards getting them to the pump and getting them to either the norepinephrine or the epinephrine that they need once you do safely make it to the truck. So again, we'll touch on that a little bit during in-person training, but this is where we've moved away from sort of pushing norepinephrine at the bedside. You'll be able to use push-dose epinephrine instead. And during the procedure training coming up in 2 cycles from now, we'll actually go through the mechanics of making that push-dose epinephrine. So the crashing patient trauma page, as you've already been trained on, is a new page. It's now incorporated in the protocol set. There's not been any real changes compared to when we trained it on the onset, but it is now included as part of the protocol update. All right, the shock hypotension page. So I'm going to start at the BLS level here. So for the basics, your primary change is that if you have a patient who is in shock or is hypotensive and they have a gravid uterus, then make sure that you try and displace that uterus. So either by manually displacing it to the left or especially if the patient's conscious and cooperative, have them lie on their left-hand side, or the left lateral decubitus position helps offload that uterus and relieve pressure off the inferior vena cava to allow that blood flow to return. So for the assist level on the shock hypotension page, the big changes here are we've sort of clarified what cardiogenic shock is. It used to say cardiac before, and we wanted to just make clear that what we're talking about in this middle box here is cardiogenic shock patients. So that's patients who have undergone left ventricular failure from a big MI or worsening heart failure. And the goal there is to give them a small bolus of intravenous fluids with a titrated goal of about 90 or so. And then to move on down the pathway, not to continuously try and bolus them 2 full liters, because patients in cardiogenic shock oftentimes are volume overloaded. And then we clarified a little bit here about what we meant by general medical. We're talking about sepsis, medical bleeding, that sort of thing. This is your patient that you're able to give a full 2 liters of normal saline to, and especially if you have a patient with sort of signs of severe sepsis, then you'd want to make sure that you bolus them adequately. And then at the assist level as well, we are implementing the vasopressors of push dose epinephrine. So again, you're going to be trained on physically how to perform this. It's actually a relatively straightforward thing to do. You take a 10 ml flush, you squirt out 1 ml of saline, you draw up 1 ml of your 1 in 10,000 epinephrine. So you now have a 1 in 100,000 solution, or basically 10 micrograms per milliliter. And then you'd administer 10 micrograms at a time, up to a total dose of 50 micrograms or so. And again, the goal of this is to just support that blood pressure as a temporizing solution towards getting to vasopressors. So, or towards getting towards the vasopressor infusion. So the norepinephrine pump that's going to take a little while to set up. This is your stopgap towards someone who's adequately fluid resuscitated, but still hypotensive and waiting on the pump to get set up, or to actually be able to safely move the patient to the ambulance to get them set up on the pump. This is where push dose epinephrine is going to come in. A couple other changes at the advanced level. So we've added a new indication for TXA. So as you see here, anybody who has a traumatic brain injury with inability to follow verbal commands, so simply a motor GCS score of less than 5. So basically, you ask them to do something, they're unable to follow suit. Anything less than that is going to be eligible to receive TXA. And then another new thing about TXA is it's actually a 2-gram push. It's no longer an infusion that needs to be done. There's been a number of studies that looked at the safety of an infusion versus a bolus of TXA, and we'll now be upping the dose to 2 grams, but we'll also be slow pushing it over a minute as opposed to the 15-minute infusion you had to do in the past. Again, still the time limitation, so do not do this if the injury occurred over 3 hours ago, because there is some degradation of outcomes after that time frame. And then the other few big things you're going to see sort of across the board here, both for your epinephrine infusion and your norepinephrine infusion, is that you're actually going to start at a higher dose now. You can start at 5 micrograms per minute. Your range is still 2 to 30, but you'll start at a higher dose, trying to get that pressure going and circulating through the system, and then you can adjust and titrate as needed. And then lastly, we've had a number of patients with known adrenal insufficiency, so known Addison's disease or some sort of adrenal insufficiency. And historically, you needed to call to get authorization to administer a dose of steroids. I want to be clear about this. This new update is going to be for patients who have known disease. So their family member tells you, hey, she takes steroids when she gets hypotensive because of known Addison's disease. And in those types of situations, you can go ahead and give them dexamethasone standing order. You don't need to call us for it. If there's a question or a concern, as always, please feel free to reach out during the case through the OLPG line, but this is standing order. Having said that, this is not for patients that you think might have adrenal insufficiency or Addison's disease, that don't have a known diagnosis or aren't able to, no one on scene is able to tell you that that's their diagnosis. Don't go giving steroids, at random to hypotensive patients. That's not the goal here. The goal here is to give it to patients that we know will benefit from it, and to administer the dexamethasone for them. All right, respiratory insufficiency and failure. So let's start again at the basic level. Historically, the supraglottic airway box was down in the assist level. I think the goal of that originally was to show that we had an allowance for either endotracheal intubation or supraglottic airway at paramedic discretion. That is still the case, but in technicality, a supraglottic airway can be placed by a basic provider. And so we simply took the box and moved it up to the basic level to maintain consistency. And again, to be clear, if you are a basic provider and you don't have an ALS provider on scene, you are within your rights to administer or to place a supraglottic airway if the patient tolerates it and they're in respiratory failure, etc. So that's what that box says there. For the ALS level, we simply moved over the IVIO access box just for cleanliness sake, and not a whole lot else really changed here. And one of the other changes you're going to see sort of across the board is this switch from the term CPAP to this term NIPPV, or non-invasive positive pressure ventilation. There's a reason for that, is that we are going to be switching devices here soon from a CPAP only device to a BiPAP/CPAP device. We'll cover that in the procedure section and in the procedure training. But across the board, you'll see CPAP noted as NIPPV now because of that dual mode that's available. The traumatic cardiac arrest page has been included into the protocol set. Again, you were trained on this during the last CE cycle. It spans both the basic, assist, and advanced scope of practice, and really has not changed since that initial training. Remember, again, your hot algorithm: hypovolemia, oxygenation, and tension in the thorax. The goal is to work these patients on scene if safe, meet your hot algorithm, spend 15 minutes trying to resuscitate them. If you're unsuccessful in resuscitating them, the likelihood of any positive outcome coming from transporting that patient to the hospital is essentially zero, and that's why we perform traumatic termination of resuscitation. But it should be a team-focused approach with the goal of controlling catastrophic hemorrhage, fixing your hot problems, and then moving on from there. All right, acute pain management, a few changes here. The first one being at the basic level, that we have now included ondansetron or Zofran ODT at the basic level. This was one of the great outcomes from our protocol committee that we worked together on, is that ODT Zofran is a relatively safe drug with fairly few contraindications. And so that is now a BLS level skill and can be done as part of the basic scope of practice. For the assist and advanced providers, we're going to be implementing a new drug for patients with a pain score over 6, and that's going to be ketorolac or Toradol. So ketorolac is a non-steroidal anti-inflammatory drug, much like ibuprofen and naproxen. It is a parenteral drug, so it only is available in sort of IV or IM formulations. The dosing changes a little bit based on whether you're giving it IV or IM, so it's 15 milligrams IV or 30 milligrams IM. The big concerns with ketorolac really are in relation to bleeding. There's always a little bit of concern about patients who might be going to surgery or have known bleeding disorders. We've got a full list of indications and contraindications in the pharmacopoeia, but this will be a great new drug for us to be able to use. It's listed here next to fentanyl, and I want to be clear, I didn't want to make it and or. You don't have to give, you definitely should minimize giving both. The goal here is use your discretion, use either ketorolac or fentanyl. If you have to use both because you feel like one hasn't worked as well, then you can use the other, and that's fair. But it's not one or the other, and it's not both. It's really clinician discretion. So again, be judicious, call us with issues, and that's that new drug. And then lastly, one of the things we still get called about a lot is this question of benzodiazepines for muscle spasm, especially fracture-based muscle spasm or patients with muscle spasms, and especially in relation to administering them alongside opiates. There's two real downsides to this. One, benzodiazepines actually don't work for muscle spasms. You look at the literature across the board, it's not indicated. It doesn't actually help. Most of the spasm, the pain from the spasm can be resolved with pain medication and adequate analgesia. And so that's what our main focus is on administration of opiates or NSAIDs now for control of pain. But also when you do co-administer it with opiates like fentanyl, benzodiazepines have sort of a compounding effect, and it can lead to excessive respiratory suppression. It can lead to excessive sort of mental suppression. So we like to avoid it as much as possible. So on the whole, we're going to focus on our analgesics as opposed to any benzodiazepines for patients with spasm. That's that. One other change here is that fentanyl, you now have a full 3 repeat doses. Essentially, you can finish out your narcotic pouch if needed. Again, use your clinical suspicion. Don't be flooding people with fentanyl, especially because the longer it stays in their system, the more likely there is to have a compounding effect. But for those long transports, such as the burn patients or the LDTs and things like that, you have a full gamut there of your pain medication. Just use it judiciously. All right, non-traumatic termination of resuscitation, so your medical cardiac arrest. A few changes here that we're going to touch on. So firstly, when it comes to what's required to terminate cardiac arrest. So again, remember the goal of termination of resuscitation is to not have to load and go with these patients that like we used to way back when and transport them all to the emergency department. You all are the experts at resuscitating people, whether it's in the field or otherwise. And so their best chance of getting a ROSC is with you working them on scene. So there are a few things, though, that have to be done in order for us to say that we put our best foot forward and really gave the patient our all. So historically, it said advanced airway placement. And I think we all realize that advanced airway placement is not the mainstay here. What we're really trying to get at is that you need effective ventilation, right? You have to show that you are breathing in oxygen and expiring CO2 for a period of time to show that oxygenation and ventilation is occurring. So we've removed the requirement of advanced airway management and said confirmed effective ventilation. That means that you have CO2 coming out with a good either BVM, supraglottic, endotracheal intubation airway, and that you're ventilating them for a period of time, plus high quality CPR, plus ACLS drugs. Okay, and so those are the big requirements to actually start looking at a termination of resuscitation. There's a few things to keep in mind, though. If you spend 20 minutes trying to achieve ventilation and then 2 minutes afterwards say, well, we got our ventilation, but the patient still didn't come back. Let's go ahead and do termination now. That's not really the goal here, right? So the goal is that they need to have some prolonged period of confirmed effective ventilation. That's partly why our goal should be to manage that airway effectively earlier on in the case, rather than spending the entire arrest trying to work on the airway. So again, confirmed effective ventilation as documented by a standard CO2 waveform, plus high quality CPR, plus ACLS drugs. A couple contraindications that we wanted to touch on. So the first one, it used to say witnessed arrest here, and obviously I think we've mentioned before, really the goal with that was EMS witnessed cardiac arrest. So if a patient goes into cardiac arrest in front of you, you shouldn't terminate those patients. There are plenty of patients that will go into cardiac arrest in the presence of a family member and other things. Those patients have just as good of a chance of survival, if not better, hopefully due to some bystander CPR. But it should not stop you from doing termination or resuscitation. It's really talking about EMS witnessed arrest. CPR-induced consciousness, which you're going to see a little bit about here in the next couple of slides. CPR-induced consciousness is a phenomenon by which the patient achieves such good cardiac output during the CPR and resuscitation that they actually wake up a little bit or make purposeful movement. That's considered an exclusion to most termination and resuscitation protocols. So if you have a period of CPR-induced consciousness, don't do field term on those people. And then the last one is this concept of public view. And, it's always been a little nebulous as a system. What we're really talking about is patients who are, purely and easily visible by the public. So, we're talking about in the middle of a grocery store in aisle 7, that we're doing resuscitation. Those patients should probably be, resuscitation initiated and stabilized and transported. But we're not talking about people who can easily be hidden from public view. So if they're in a back storeroom or if they're in an office building out of sight, those sort of things are not really required to be transported, because again, the best chance of resuscitation of success is going to be with you working them on scene as opposed to focusing on moving them out of the location that they were found. Another change on here is the concept of defining persistent VF or VT. So it used to just say persistent. We're essentially saying 3 or more defibrillations is persistent VF or VT. And so in general, that would be 3 successive defibrillations. So you had 3 pulse checks and 3 defibrillations. If those are spaced out by a period of asystole or PEA, that can happen. But if you have a really persistent VF-VT, if it's coming back and you're shocking it more than 3 times, those patients have some likelihood of successful resuscitation, and so we should actually transport those patients to the hospital. And then lastly, one of the questions that comes up a lot is, well, when does our timer start for our 20 or 30 minutes? And really, there's not a great time frame, but when you look back at the studies and really what a lot of EMS agencies are doing, the time really starts when the first credentialed provider arrives on scene. So if you're a firefighter and you get on scene and you start doing a good BLS with an AED, then EMS arrives. Or if you're an EMS unit that arrives first, and then fire comes to help out too. It's whoever got there first and started the resuscitation. That's really when it starts, because it's the CPR that's the most important. Bystander CPR does not really count in that time frame, mostly because it's hard for us to verify adequacy of CPR. So that's when the time clock starts, and you can go based on that. For traumatic termination of resuscitation, there's really not any changes except for what we spoke about with non-traumatic termination, that the time really starts when a credentialed provider arrives on scene and starts the resuscitation. So what about withholding of resuscitative efforts? So a couple changes here. So the first one is what we call head under submersion. And really what that means is essentially a drowning. So a head under submersion means a person is fully dunked in the water for a prolonged period of time. It does not include patients who are trapped in a vehicle in the water because they're surrounded by an air bubble. But if you have a patient who has been underwater for 90 minutes in very cold water, so 90 minutes in a water temperature of less than or equal to 6 degrees Celsius or 43 degrees Fahrenheit, or 30 minutes if the water temperature is warmer than 6 degrees Celsius. This obviously has to do with the protective effects of hypothermia and the protective effects of cold water submersion. There is a higher chance of survival for a longer period of time in very cold water. This can help guide sort of rescue versus recovery efforts, as well as when a patient is removed from the water, the time of submersion, or at least approximate time of submersion, will give you some guidance as to whether or not you should begin resuscitating these patients. And lastly, there's a new type of advanced directive called a MOST, or Medical Orders on Scope of Treatment, or POLST, Physician's Orders on Scope of Treatment. And really a MOST or a POLST form it's very much like an advanced directive or a DNR, but instead of being a legal document, it's actually a set of medical orders. And the nice thing about this is that it can lay out in sort of closer detail what a patient wants at the end of life. And so whereas with an out-of-hospital DNR form, there's really only a single set of things, such as no BVM, no pacing, no CPR, advanced airway management, etc. A MOST or a POLST form can actually detail out that the patient would be okay being intubated and placed on a ventilator, but would not want CPR, for example. It's very much like a standard advanced directive in that way. If you do come across a MOST or POLST form, you are now authorized to honor it. So read through it, make sure it is signed by the physician accordingly, and then you can limit the care based on the MOST or POLST form. If there's any issues that come up or discrepancies, or if you have any questions, please feel free to call us. These do not have a standardized form, and so but they are often brought forth by health systems. So you may see a hospital logo on them. They're usually signed by a physician and as well as the patient, and it goes into detail as to what medical treatments they would want or not. So you're within your rights to honor those, especially to honor the patient's wishes. All right, on to the adult cardiac section. So adult cardiac arrest, just a few changes. So one, you're going to see this move away from the term King LT and just towards supraglottic airway, just to standardize the nomenclature really throughout the protocols, but no real change to the medicine here. Another mention for patients with a gravid uterus, so large uterus in cardiac arrest, manually displace that fundus to the left side. You remove that pressure on the inferior vena cava, allow blood to flow back up and circulate. At the assist level, what we've done is really, again, qualified that 3 defibrillations is the definition for someone in persistent or recurrent VF or VT. And there's a few things that happen there. One, obviously, you give your second dose of amiodarone. But secondly, we talked about this change in pad placement. So one of the things that our system does sort of uniquely is this anteroposterior pad placement. And we've looked at the science a lot, both from a large study perspective and some of the basic science research. And really, we're advocates for the heart sandwich. Get the pads as close and around the heart as possible when you're going to defibrillate. One of the prevailing theories about dual sequential defibrillation is that it's not really the two monitor shocks that are really doing it. It's that change in vector for one of them. So oftentimes when people do a DSED, they put one in the AP placement and one in the anterolateral placement. And so what the science is really moving us towards is if you've tried 3 times in one configuration, go ahead and for your subsequent shocks, go ahead and change your vector because or actually change the pad placement to get a different vector of electricity going through the heart. That may help overall increase your chance of that next shock success. And then as I mentioned before, for patients with CPR-induced consciousness, so your CPR is so great and their cardiac output is so good that their cerebral perfusion pressure is allowing them to be awake. And oftentimes they can interfere with the care. So for those patients, you can actually go ahead and give them ketamine. That will help protect their blood pressure, but also sedate them adequately in order to prevent any interference with care. The sort of signs and symptoms of CPR-induced consciousness are outlined at the bottom here. We talk about combativeness or agitation. Purposeful movements are really a big one if they're pulling at your airway device or lines, or they're withdrawing away from compressions. But obviously, all of this is without a return of spontaneous circulation. So these things only occur while you're doing CPR. Then you can administer ketamine. And then again, that upping of the epinephrine starting dose for patients in beta blocker overdose. If you are successful in resuscitating them and you think it's a beta blocker overdose, when you begin your epinephrine infusion, you can start it at a higher dose there. All right, ischemic chest pain or acute coronary syndrome. So at the basic level, again, this call out for severe nausea or vomiting, referring to that nausea and vomiting protocol, which has the treatment of ondansetron ODT, as I've mentioned in some of the other protocols before. And that's really the only change for the basic level. And at the assist level, really a couple quick items to mention about patients with STEMI. So one, what we've done is actually moved the identification and actions for STEMIs into the assist level protocol, especially as we talk about operating as a system and really the FRO, ALS FROs having the ability to not only recognize STEMI, but alert hospitals in anticipation of transportation. This has moved it up to the assist level. One other thing to make note of is that STEMIs frequently decompensate into shockable rhythms. So, and really when that happens, really time is of the essence. So if you do identify a STEMI, one of your early steps should be the placement of defibrillation pads in anticipation that they may end up decompensating, because really for every second or every minute that a patient goes into ventricular fibrillation, your overall chance of shock success goes down. So if you already have pads on, you're able to quickly charge them and shock it, as opposed to having to recognize it, get the pads on, then charge it and shock it. Hopefully you'll be able to save a few seconds there. So for the symptomatic bradycardia page, no real changes at the basic level. At the advanced level, historically there was actually a OLMC requirement for administering midazolam if 3 rounds of ketamine had failed for a pacing sedation. Thankfully, we've never reached that situation, and also if we have, I haven't heard about it on OPG, so we removed that. And then again, the conversation about starting at a higher dose of epinephrine for shock hypotension, as well as for beta blocker overdoses. Again, small changes there. So on the adult allergic reaction page, there's no real changes at the basic level. Down at the advanced level, again, you have that new starting dose of 5 micrograms per minute if you're giving an epinephrine infusion for severe anaphylaxis. Again, remember, severe anaphylaxis is actually easier to be in than you think. If you have any sort of oropharyngeal swelling or severe dyspnea, stridor, wheezing, etc., IV epinephrine is the go-to drug of choice. And the safest and sort of cleanest way to do that is an epi infusion here. If you don't have an IV started yet, or you need more rapid administration, you can start with intramuscular epinephrine, but be prepared to do that epi infusion down the line. All right, for the adult altered mental status and CNS depression, no changes at the basic level. Down in the advanced level, the administration for thiamine, which we give remarkably often, has gone away. So again, the risk of Wernicke's encephalopathy is actually relatively low. If you do have a patient that you are concerned for Wernicke's encephalopathy, then you can use glucagon or something as opposed to pure dextrose to try and prevent that. But in general, I don't think we were catching a lot of it, or rather, it wasn't really out there. So we've removed thiamine as a drug in the formulary. And then again, that new starting dose of 5 micrograms per minute of epinephrine infusion for beta blocker overdoses, which you'll continue to see throughout this book. All right, adult behavioral emergencies. So the big changes here at the advanced level. So remember, it is standard across all behavioral emergencies to start with midazolam. Okay, that is our first line agent, and that is really what we should be going to first. It's the safest drug across the board. It will work in the predominance of cases. Once you've given your dose of midazolam, if it doesn't work, you essentially have a few options. The first thing is to really assess, what do you think the underlying cause of agitation is, okay? The first option is excited delirium. And I want to be clear, excited delirium is real, but it's a very specific type of process. So down at the bottom, we've sort of listed some things that point you towards excited delirium. So tachypnea, they're hyperthermic, they're have an extremely high pain tolerance, they're non-compliant, they're agitated, they're aggressive. Go online, look up some YouTube videos of excited delirium, and you'll see a true excited delirium will need ketamine to control, and that's okay. In the appropriate patient situations, use of ketamine for sedation is appropriate. If it's a known psychiatric disease, right? So we'll say schizoaffective disorder, psychosis, or alcohol intoxication that is causing a severe agitation with the need for sedation, then actually your haloperidol or sort of dopamine agents is going to be your most effective and real safest drug. So antipsychotics for patients with psychosis, again, haloperidol 5 milligrams, for example, in those patient populations. And then really for everyone else, including anyone that you're really not sure what's going on, if they don't really point totally towards a psychiatric disease or totally towards excited delirium, then you can go ahead and use further midazolam. All right, because again, I'd rather you continuously give benzodiazepines and sedate someone in a relatively cardiac safe fashion than anything else. What we've seen over the past couple of years is a little bit of drift in terms of the drug choices. So oftentimes we don't see midazolam being used first. Sometimes we see ketamine being used for patients that are not in excited delirium, see haloperidol used for patients that probably need ketamine, etc. So again, use your judgment. If you have any questions about the definitions or want to see some examples or anything else, let us know. We can show you some. But again, the goal here is, if you treated the patient with nothing but midazolam, that would be fine. If you have a great clinical suspicion for one of these other disease processes, then you can use the drugs as appropriate. All right, adult nausea, vomiting. So again, a few other pages call out to this is what you're going to see. The two real big changes is, one, as I mentioned before, we moved ondansetron or Zofran ODT up to the basic level. Again, it's a relatively safe drug that can be used and is used by the outpatient population a lot. So you can give a second dose after 10 minutes or so if their nausea has not resolved. If they're actively vomiting, the ODT tablets do dissolve, but if they end up vomiting relatively shortly thereafter, or after you've given it, it may not work as well. So if they're actively vomiting, try and avoid the ODT solutions. Zofran IV is still in the assist level. And then lastly, we're going to add in haloperidol. We're going to add an indication for haloperidol in this assist level as well. And really, this is for patients who haloperidol will work well for. So patients with suspected gastroparesis. So they're diabetic, they have poorly controlled glucose, and their stomach has trouble emptying, or if they have a known diagnosis of gastroparesis, or patients with cyclical vomiting syndrome. So they have a known diagnosis of cyclical vomiting syndrome. It causes profound and uncontrollable vomiting that Zofran oftentimes doesn't work for. Haloperidol is a great drug in both of those clinical situations. You can give 2.5 milligrams IV. That's what I use in the emergency department. Push it relatively slowly if possible. I know it's a small volume, but try and minimize some of the sort of dystonic reactions with some slow administration, and we'll see how that goes. All right, so adult overdose poisoning. So if you remember, about a year or so ago, we put out a medical directive on naloxone and really the indications for it. We still to this day see naloxone given to a lot of patients that don't meet the traditional definition of opiate toxicity. So again, we're looking for miosis or pinpoint pupils, respiratory depression, and CNS depression. It's not one or the other, it's really all three. And you can give the naloxone intranasally, or if you're a paramedic at the assist or advanced level, you can give it intravenously as well. The goal here, again, is to improve their respiratory drive, not to bring them to alertness and not to put them into full withdrawal. A quick mention about caustic ingestion. So if you have a patient with caustic ingestion, don't give them anything to eat or drink. Try not to induce vomiting. Sometimes they get advice from other people to induce their vomiting to get rid of caustic substances like bleach or acids or that sort of thing, to try and avoid that. Again, the conversation of the indications for naloxone at the assist level. And then lastly, that 5 microgram per minute starting dose of epinephrine for your beta blocker overdoses as well. For the respiratory distress page, the only change across the board is the nomenclature change from CPAP to NIPPV, or non-invasive positive pressure ventilation. Not really any medical changes other than that. Seizure and status at the advanced level. One of the things we've done is updated our magnesium dosing for patients in eclampsia or peripartum seizure. You're going to see this 4 grams IV over 10 minutes, followed by a 2 gram an hour infusion. The IV route is preferred, but if you can't get an IV, especially in a bad seizure, after you've managed them with the midazolam, you can actually administer it intramuscularly as well. The 2 gram infusion, 2 gram per hour infusion, obviously through an IV afterwards. All right, moving into the environmental section for adult bites and envenomation. Just one small note. Based on some evidence that came out that we didn't have mention of, is obviously if you have a bite involving the extremity, we're already immobilizing the limb below the level of the heart. We're already removing all jewelry, but just don't wrap it. You can loosely cover it, but you don't need to wrap it in ACE bandages or pack it with ice or anything like that. Try not to add any tightness. The goal there is if the swelling starts, a lot of them can progress quite rapidly, so you want to have room for swelling to occur. For hyperthermia and heat stroke, 2 real changes here. The first, at the basic level, historically we've talked about ice packs being placed in the axilla, the groin, sometimes the hands and feet, that sort of thing. Having taken a deeper dive through the literature now, it looks like the most effective method to cool a patient using ice packs is to actually place it on the trunk or abdomen, especially if you can cause some air circulation where the actual hot air is removed after evaporation. So if you have the fans running and ice packs to really the trunk, abdomen, etc., that's going to have the highest surface area to ice contact ratio, and is going to pull off a lot more of that heat. And then at the assist and advanced level, if you do have chilled IV fluid, so if you have a fridge in your ambulance or in your engine, and you've got normal saline in there, you can administer or should administer chilled IV fluids preferentially, and then obviously normal temperature fluids if you don't. In hypothermia, the only real change here is this addition, again, as we talked about in the withholding of resuscitation protocol, for head under submersion, water submersion. Obviously, again, not vehicular submersions, but a patient who's drowned in cold or warm water. Remember that cutoff is 6 degrees Celsius, 90 minutes or longer in less than 6 degrees Celsius, or 30 minutes or longer in less than 6 degrees Celsius allows you to withhold resuscitation. In the adult near drowning, again, 2 pretty small changes. One is that nomenclature change from CPAP to NIPPV, or non-invasive positive pressure ventilation. And then again, that head under submersion, the 90 or 30 minutes based on the temperature of the water, whether it's colder than 6 degrees Celsius or warmer. All right, on to the trauma section. So for adult general trauma, a couple changes here. The first one being really this adjustment to head and neck injuries as a title here. One of the things we want to talk about is if you do have a patient in respiratory failure from trauma, so whether they're intubated or you're performing bag valve mask ventilation or something like that, keep a relatively low respiratory rate, so something like 10 beats or 10 breaths per minute. That's normal. You can aim for your end tidal of 35 to 45 as sort of a range there. The goal there is to minimize any rise in the intracerebral pressure or sort of blowing off of too much CO2 there, which can be protective. Same thing, if you do have a patient with a head or neck injury, you want to keep their blood pressure up. So if they are hypotensive, you want to aim for a systolic pressure of at least 120, and then again, maintain that end tidal CO2 between 35 and 45. And then for patients who are pregnant, again, like we talked about before, if they are a trauma patient and they're pregnant, try and get them in that left lateral recumbent position to alleviate that pressure off the inferior vena cava. And if they have bad cardiac output, physically displace that fundus so that you've relieved that pressure. And then one note is sort of this care of amputated body parts. We've had a couple cases sent to the hospital, without the part being either brought or cared for appropriately. So we have a specific mention calling out the care of amputated body parts on a separate page. And on that amputated body part page, just a couple notes there to make sure that, place it in a watertight plastic bag. Don't freeze it, don't soak it in water or macerate or anything, and then obviously bring it with the patient to the emergency department. One thing that we have a misconception of in this system is where and what can be reimplanted. I think the important thing is that there's no such thing as a reimplantation center. There are different specialists on call across the hospitals, both in Fort Worth and in sort of the surrounding region of DFW. Take it to a trauma center that has orthopedics, which is really all the trauma centers. They'll know what to do with it, whether it's transfer them out or take care of it in that hospital. So spinal motion restriction, no real big changes to the indications, except for one, which is really been in the literature for a number of years now. Patients with penetrating trauma, so we're talking about gunshot wounds or stab wounds or things like that to the neck or to the spinal cord, whether they have neurologic deficits or not, they do not need to be placed in spinal motion restriction. Now, that doesn't mean have them bend over and twist sideways and move all around. But the reality of it is when you have a patient who's been shot and has involved the spinal cord, or if they've been stabbed, et cetera, that damage is already done. There's no new damage that's going to come from them not being on spinal motion precautions. But in reality, using a spine board or using any other sort of hard device on those patients actually does increase their mortality a lot of times due to respiratory drive problems. And so treat them like normal. You don't necessarily, you don't have to put them in a cervical collar, for example, if they're shot in the back, or if you have patients who are otherwise shot in the abdomen, for example, they don't need spinal motion restriction precautions. They can be taken care of like normal. All right, onto the OB section, and we're actually going to do a sort of real deep dive in OB during one of the upcoming CE sessions, but just a quick mention down in the advanced section, like I mentioned before, just standardizing that magnesium sulfate dosing for patients who you suspect to be in preeclampsia. So again, greater than 20 weeks gestation, up to 6 weeks postpartum, hypertension, whether it's systolic or diastolic, symptoms of preeclampsia like headache, altered mental status, vision changes, pulmonary edema. Give the magnesium sulfate 4 grams IV over 15 minutes, followed by a 2 gram an hour infusion. Okay, and then that'll help bring down their pressure, and it'll also help prevent them from going further into seizures. And then also as part of OB, but also technically a little bit of pediatrics and neonatal, our newly born protocol. So this whole page has essentially been revamped. It follows the new neonatal resuscitation guidelines. Again, you're going to get more in detailed training on this in the upcoming CE session. But just to sort of give you a little overview, obviously patients that are babies that are delivered, you warm, dry, and stimulate them. That's a normal thing to do. That generally takes care of it. Most infants are fine. Clear secretions as needed. You don't need to suction them every time. Most babies can handle their own secretions at the time of birth. But if it is getting stuck or you need to, then go ahead and clear it with a bulb syringe. Look at their breathing pattern, feel their pulse rate. Obviously, under their brachial or feel at the brachial artery is probably the easiest. Look at their breathing pattern. If they're apneic or gasping or their heart rate is low, they may be in distress. Most babies can easily be resuscitated with just a little bit of bag valve mask ventilation. So relatively fast at 40 to 60 breaths per minute, but relatively small volumes given their size. And you don't really need to even attach it to supplemental oxygen. Too much oxygen in the neonatal period can actually be detrimental. So if it's a sort of breathing rate issue, go ahead and give them a frequent small breaths with the BVM on its own, and that should resolve their symptoms. If their heart rate continues to drop after 30 seconds of good confirmed BVM ventilation, then go ahead and begin CPR. It's actually a very fast version of CPR to ventilation ratio, so it's a 3-to-1 compression to ventilation ratio, the whole thing being at 120 events per minute. And then moving down into the ALS timeframe, there's actually a push towards endotracheal intubation if you are doing CPR and providing this amount of assisted ventilations. Of note, all of these things, the warm, drying, stimulating, the assessing their heart rate and respiratory rate, and getting down into either assisting with BVM or beginning CPR, all of that should really only take about a minute or so. All right, that's really your goal time frame. When you assess the breathing pattern and palpate the pulse, if it's labored or there's persistent cyanosis, but they're not apneic or gasping and they have a normal heart rate, then simply position and clear their airway. You can provide a little bit of supplemental oxygenation as needed, but you don't need to start bagging them just because they're blue or if they look like they have a little bit of labored breathing. You can place them on a pulse ox. Remember, go on the right hand, so you're getting a pre-ductal SpO2, so before it starts mixing with deoxygenated blood. Remember, those blood vessels from the fetal time frame are open in that immediately neonatal time frame. So you want to go on the right hand is really your ideal solution. From an ALS perspective, if the heart rate's under 100 and you're still giving good BVM, try and make sure, as much as possible, whether you're able to use waveform capnography or assessing chest rise and fall, that the BVM's working. If you're getting to the place of beginning CPR, then go ahead and perform advanced airway management. You can actually do that if you're having trouble with your initial BVM, but your heart rate's between 60 and 100. And then if you still have a low heart rate despite CPR, you can actually, at this point, administer epinephrine. That's sort of the go-to there. And at that point, again, this whole process really only taking a few minutes, at that point, you would initiate transport to a pediatric facility. So again, you're going to get more detailed discussion on this in terms of the neonatal resuscitation timeframe through some of our live training. All right, that brings us to the pediatric section. So we're actually going to do a focused update on pediatrics. It's part of our live CE. We'll be covering a number of the items that I'm going to bring up sort of briefly here. So we'll just take a quick go through, but most of the training will be done as part of our upcoming live training. So the patient assessment page has a number of changes. One, we wanted to include a definition of a pediatric patient. So again, we've been decently good at this across the board, but we realized we probably should spell it out. So in our opinion, if you're 14 years of age or older, and either you fit on a resuscitation tape like a Broslow tape, or you have a known or estimated weight less than 36 kilos, which is about 80 pounds, which is the highest limit of a Broslow tape, then you're considered a pediatric patient. And there's a whole host of other ways that you can identify who's a pediatric patient and who's not. But for the most part, that's a relatively straightforward definition that we're going to go with. The only caveat there is that does not necessarily apply when it comes to destination decisions. So again, in the destination policy, there's specific age cutoffs for trauma versus medical versus psychiatric, based on what the hospitals in the region will be able to accept. So from a destination decision standpoint, this doesn't apply, but for the most part, a pediatric patient is defined as 14 years of age or younger and either small enough to fit on a resuscitation tape or has a known weight of less than 36 kilos. We've also added in really a pointed reference to using a reference guide, whether it's a link-based resuscitation tape like a Broslow tape, or one of the things that we'll be rolling out here over the next few months is that the protocol app that most of you use, so it's called PPP Provider in the sort of app world, will soon be updated to also include a couple things. The hyperlinks will start being real, and also it'll have a pediatric dosing guide. So you'll be able to click on each drug, put in the weight of the patient, and it'll give you all of the doses based on our dosing scheme of what you should give. And so that should hopefully help with some of our pediatric dosing here in the future. So make sure you use a reference guide as we treat our pediatric patients. So one of the big areas for focus in our upcoming training is actually a crashing patient protocol set for pediatrics as well. So you can go ahead and start looking at it here. Again, it's very similar to the adult crashing patient protocols, both in concept and in action. It has goal-directed therapy with specific resuscitative goals that you should meet before calling a patient stable enough to transport them. So that applies both for medical and trauma, and you'll be getting this sort of in detailed training as part of the upcoming sessions. For pediatric shock hypotension, along the same lines as adult, again, if you have a child with a documented history of Addison's disease, so they are hypotensive, they have known Addison's disease or adrenal insufficiency, and really for the kids with explicit parental consent. So the patient is asking you, or the patient's parents are asking you, hey, normally we give them steroids. Can you give them a dose of steroids to help get them over this? Then yes, you can give them dexamethasone as per our standard dosing. For the pediatric respiratory insufficiency and failure, really the same changes as it was for the adult, just moving the supraglottic airway allowance up to the basic level out of assist. It already was in practice, but just moving that up to where it really belonged. And then again, this allowance for if you don't have an ALS provider on scene, if you've got your end-tidal CO2 capabilities, then you're within your rights to place a supraglottic airway. Again, like we added to the adult protocol page, there is now a pediatric traumatic cardiac arrest page focusing on very much the same things: hypovolemia, oxygenation, and tension pneumothorax, with really a goal-directed guide for working the resuscitation. Obviously, on a pediatric traumatic cardiac arrest, we don't perform field termination, and so again, the goal here being how to maximize your treatment on scene to maximize the patient's chance of return to spontaneous circulation prior to transport. For your pediatric acute pain, again, same changes on ondansetron ondansetron ODT at the basic level. Again, go by your weight. You essentially can give a full ODT tablet or try and split the tiny pill in half for those in the 8 to 15 kilogram range. But again, that's moved up to the basic level. And then we have added ketorolac down here at the assist advanced level as well. I think the important consideration here is, again, much like with the adults, it's really not a both or. It's use your clinical discretion as to what you think the patient needs, whether it's fentanyl or ketorolac, again, both for a pain score greater than 6. And then if you need to, IV ondansetron still in that assist level. And then the last part of the general section for withholding of resuscitative efforts at the basic level, same conversation about head under submersion, 90 minutes if it's less than or equal to 6 degrees Celsius, or 30 minutes if it's greater than 6. And then this concept again of the medical orders on scope of treatment, or physician's orders on scope of treatment or pulse form. Again, you can limit it based on a most or pulse form being filled out correctly. Again, this will allow you to, or allow the patient and their physician to really fine tune what their end of life care really looks like. On the pediatric cardiac arrest page, no real big changes. We removed a top line here that was a duplicated line for advanced airway management here, but nothing big. Moving on to medical pages for pediatrics. So the alternate mental status page. So we're going to talk again about this in the live session, but there's this concept of what used to be called an ALTI, or an acute life-threatening event, but is now called a BREW, or a brief resolved unexplained event. This is a phenomenon of really kids under the age of 1 who have a brief period of time where they go unresponsive and really don't react, and they may turn blue, they may appear very unwell, and then it resolves essentially on its own. This is actually, without really identifying an underlying cause, this actually puts them at high risk of sudden infant death syndrome and a few other sort of dangerous conditions. And so there's not a lot we can do from the EMS perspective except to recognize it, right? So every so often we go back and look at the AMAs that are done on kids under 1. And there are absolutely cases that meet the definition of an ALTI or a BREW, but we don't really do anything about it. The parents feel reassured that the patient looks better now. We check their vitals and they appear normal. And the parent oftentimes asks to be left, against medical advice. And I think it's important that you keep this at least part of your differential and part of your AMA risk discussion, so that the parents are adequately informed about what a brew is and what it could potentially lead to. So importantly, you'll need to get a thorough history, really looking at what the symptoms were, what did they look like, what they were doing before, after, their color, tone, whether they were feeding or not, etc. And then really, if you are concerned, really strongly encourage them to be transported to a hospital. Down there in the Pearl section, we have some specific definitions of the criteria for brew. And then again, we're going to cover this in our live session. And then lastly, at the assist level, again, some conversation about the requirements needed for administration of naloxone, really the definition of opiate intoxication being meiosis or pinpoint pupils, respiratory depression, and CNS depression, the goal being to identify all three, not just one. For pediatric overdoses and poisoning, again, same changes as the adult. The indications for opiate intoxication being meiosis, respiratory depression, CNS depression, caustic ingestions, trying to minimize any vomiting or patients eating or drinking. And then at the assist level, again, indications for opiate intoxication per the medical directive that we sent out a number of months ago. For pediatric respiratory distress, only real change here is a discussion about patients with suspected bronchiolitis. So again, you'll get some further information on this during the live training. But there are a number of kids, especially under the age of 2, that when they get a viral illness, they get a disease called bronchiolitis. And it's very much an upper respiratory infection. They oftentimes have a little bit of increased respiratory rate, little retractions, rhonchi on an exam, rhinorrhea being a big feature, sometimes fever. These patients generally don't need Duanebs or any sort of breathing treatment. It won't respond to them, and it also may help or may just increase their heart rate, which doesn't help very much. So if there's not a clear indication such as wheezing or real clinical suspicion of bronchospasm, you don't need to administer nebulizer treatments. One other mention at the advanced level is this dexamethasone that we're used to giving to our kids. Just a quick reminder that oral administration of the IV solution is an option and does work very well for both the mild to moderate group. We will hopefully soon be participating in a research study looking at the drugs or the dexamethasone doses that we have given by mouth. And remember that if the patient can tolerate it, they can just take that same solution orally, and it works just as well. Pediatric nausea vomiting follows very similar changes to the adult. The isopropyl alcohol that we've already been using here for a while now has been included, as well as the ondansetron ODT. You'll note we don't have an inclusion for haloperidol like we did for the adults. Generally, kids don't struggle with gastroparesis or cyclical vomiting. If they do and you think that it's indicated, as always, you can call us to discuss the case. In the pediatric environmental section, only 2 small changes, the same as in the adults. Bites involving an extremity, don't tightly wrap the affected limb, as you're already aware. And lastly, again, that change to the terminology of non-invasive positive pressure ventilation, or NIPPV, instead of CPAP. All right. For pediatric trauma, really a lot of the same changes as the adults, like in a lot of the ped sections. A special head and neck injury category now as a name change, making sure that we maintain a good age-appropriate blood pressure goal that's close to normal for head injuries, as well as minimizing any hypoxia that's occurring. And then if in respiratory failure, making sure that we give a relatively slower respiratory rate, but still within that age-appropriate zone. And then lastly, that care of the amputated body part, making sure we take them with us to the hospital. And again, that care of the amputated body part, making sure we take it with us to the hospital. And the last real pediatric trauma change, again, same with spinal motion restriction indications. If you have a patient with penetrating trauma, they do not need spinal motion restriction, especially if it's near the spinal cord or nowhere near it even. The actual application of spinal motion restriction doesn't do them any favors, so you don't need to perform it for penetrating trauma. All right, so the procedure section. So the procedure section, again, any new procedures are going to be covered in one of the upcoming live CEs. And again, we're probably going to cover, our standard skills fair worth of procedures as well. I'm going to quickly go through these pages and show you any new sort of small items, indications, style points, that sort of stuff. But again, the main training will be done in person. So for our advanced airway preparation, the only real big change here is the inclusion of a sort of size guide for pediatric intubation, both a tube and depth guide. And then really this push again that if you haven't met the goals of your crashing patient protocols, then try and avoid endotracheal intubation, whether through a direct or video laryngoscopy, especially to really just make sure you've optimized the patient prior to performing the procedure. A few minor changes in emergency childbirth. One, really talking about skin-to-skin contact immediately after delivery, as long as the neonate is doing okay. If they're vigorous and stable, you can delay cord cutting. This helps continue blood flow to the neonate, helps increase their blood count as well as oxygenation. Then clamp and cut the cord, dry and cover them, and as long as they're doing okay, you can put the baby on the mom and do sort of skin-to-skin contact. And then, of course, looking for maternal bleeding and encouraging breastfeeding to also help in the bleeding control. For our direct laryngoscopy endotracheal intubation procedure, a couple small items. So one, we historically haven't had a true definition of an intubation attempt. This is a standard definition that's accepted pretty much nationwide by most EMS services. Really, it's the insertion of a blade in the mouth with the intent of performing endotracheal intubation. So there is an older definition that some people still sort of subscribe to, which is the insertion of a tube past the teeth. The reality of it is if you're placing a laryngoscope in order to place an endotracheal tube, that is the beginning of the attempt. And so, again, our system doesn't have a maximized number of attempts. It doesn't have a minimum number of attempts. What we want, though, is to make sure we're adequately documenting our attempts and evaluating our care appropriately. So use this definition each time you go in and try and perform endotracheal intubation. This is the sort of impetus for you to document that in the chart. Now, obviously, this does not include times where you're performing laryngoscopy for foreign body removal, right? Because that's not the goal. The goal is not to place an endotracheal tube. For our intraosseous access, the real big changes here. One, we added in the indication of really severe illness or injury at risk for cardiac arrest. Again, this is more of a formality as this was already in practice. And then lastly, really this push towards using the humeral insertion as primary method of intraosseous access, and really the sort of primary site for intraosseous access, as well as defaulting to that yellow needle for that humeral insertion. So again, if you have a patient over 90 pounds with excess tissue, or anybody that you're doing a humeral insertion on, you should go ahead and use that yellow needle. For manual defibrillation, as we've talked about before, after 3 unsuccessful shocks, go ahead and change that pad placement. There may be some improvement of shock efficacy with that vector change. So if three times hasn't done it, go ahead and try a new direction. One of the things you've probably seen in this system over the past few months is this big push towards mechanical compression devices, whether it's a Lucas or a DefibTech or any of the other devices that are out there. I'm in support of this. I think it's a good move, especially from a EMS provider safety perspective. But as we've talked about before, it has to be done safely and in a well choreographed and expeditious fashion. And so there's a few things that we really need to focus on, not just our placement time and getting these on in a very choreographed way in under 10 seconds, but also making sure that we're watching it do its work and making sure it stays in the right position, doesn't slide down the chest or around the patient, and that it stays in the same place. One of the best ways to make sure it stays where it is to use the stabilizing equipment that comes with it. Whether that's the armholes or the neck strap, and quite specifically the neck strap, because what we've seen a lot of is our MCDs sort of walking down the chest and falling down towards the feet, and the placement of a neck strap would help us keep this in the right place. So this page is relatively new. It used to be the CPAP page, and as we've talked about throughout this video, it's now the non-invasive positive pressure ventilation, or NIPPV page. And part of that is because we are moving away from CPAP or CPAP alone, which really focuses just on oxygenation, to a bilevel or BPAP type device. So the same manufacturer of the FlowSafe 2 EZ, which is what we use currently in this system for CPAP, now has a bilevel positive pressure device. Again, you're going to get some good hands-on training on this, but the big difference is, whereas with CPAP alone, you provide the same amount of pressure constantly, both in inspiration and expiration, what a bilevel device does is when the patient inspires, the pressure goes up, and then when they expire, the pressure comes back down. So not only does it improve oxygenation, but it improves tidal volume, it improves ventilation, and especially improves work of breathing. And so when we talk about our patients who are in respiratory distress from acute bronchospasm like COPD exacerbations or heart failure, this is going to be a fantastic tool now that we can use to help overall improve their breathing, sort of work of breathing and oxygenation at the same time. The nice thing is the device can be used in either way. And if you're a system that currently has a CPAP device and is going to keep using them until we switch over completely, that's still allowed. The page itself, have a read through it. The bilevel device has sort of some very specific ways in which you need to set it up and actually to get that dual pressure. And one of the unfortunate downsides is that you can't administer bronchodilators at the same time as you can with the CPAP device. And so you can use it in CPAP mode and administer bronchodilators, but not in bilevel mode. So again, during the hands-on training, we're going to go through some of the nitty-gritty on this and get sort of in further detail on it. But here's the procedure page that you can start reading now. So on the pelvic binder page, we added a few things that we had talked about in previous CEs. So one, some pearls and pitfalls about when to use a pelvic binder, how to assess the pelvis for the need of a pelvic binder, remembering not to rock or spring the pelvis, as well as some sort of guidance on how to make an improvised pelvic binder if you don't have a commercially available pelvic binder to sort of use. On our supraglottic airway page, again, the only real change is the definition of an attempt here. So again, we ask that every time you place a supraglottic airway in the mouth with the plan to ventilate through it, that you would document that as an individual procedure. Again, the goal here is not to sort of put a cap on the number of attempts, but really to make sure that our documentation is accurate. When it comes to our surgical airway page, as well as what is essentially a old but new procedure of transtracheal ventilation, that's now incorporated all in this one page. We have added in the definition of an attempt, which is the insertion of a needle or a scalpel through the neck. And we've talked about when to use which type of surgical airway. So for patients over 35 kilos, we'll use the standard surgical airway approach with the scalpel and the bougie and an endotracheal tube. But for patients less than 35 kilos who have that poorly defined cartilage and wouldn't tolerate a traditional surgical airway, we'll be performing transtracheal ventilation. So again, you'll get some training on this during your hands-on session, but in essence, you insert an IV catheter through the cricothyroid membrane and attach oxygen tubing and a bag valve mask in order to help oxygenate and ventilate them as best you can for these really smaller patients who can't tolerate a surgical airway. And lastly, most of you are familiar now with the newer type of taser devices that are out there with some of our law enforcement officers. We've incorporated the sort of new procedure that we trained on a year or so ago, and really just talking about the risks there and how to actually remove both the older and new style taser devices. So that's really it. You know, I know that was a fairly rapid fire review through all of these changes. I'm sure that many of you will want to go back and watch this a couple times again to make sure that you're starting to absorb the information. Remember, this will be the beginning of your protocol training. So you will get some either live or recorded training moving forward, both into the next 2 quarters, culminating in your protocol exam and skills fair. So you've got plenty of time. Start reading, start reviewing, ask us questions, send them in, bring them to the CE sessions, come stop by the office, whatever you'd like. We're here to support you. We're here to help get this protocol through the system and make sure that it is operating across the system in the same way. And again, our goal here over the next few years is to take it down from this large batch of information that we dole out every couple years to smaller updates more frequently, so that we're keeping up with the literature on a more regular basis. So thanks everyone for your time and attention. Again, let me know if you have any questions, and if there's any changes that are made or need to be made between now and the time we go live, you'll definitely be notified of those. So thanks for everything, and we'll see you soon.